Hi, my name is Debbie Pheian. I am a registered nurse, and this is my story. I have been a nurse since 1977, and I have always been interested in vascular access. I didn't know it at the time. My first 14 years involved taking care of patients in the critical care areas, anywhere from the intensive care units with both adult and pediatrics, the neonatal intensive care unit, and the emergency room. And I learned very early that vascular access is very important, and it can be a matter of life and death in some cases for some patients. And I guess after especially the tiny preemies, when you have to repeatedly stick them to find vascular access, and you realize that there's got to be a better way. And also taking care of, I remember one baby in particular who was about 18 months old in our NICU and had never left it. And he'd been on TPN, and his vascular access was totally depleted. And he was in a really bad way one day, and the only access we could get was a vein on his abdomen, and his belly was very distended, and he was getting TPN that could not be stopped. So of course, this didn't last. And within a few days, he did die, and that was very upsetting. And you know, a bunch of us realized that there has to be a better way to take care of our patients. Back then, in the 1970s, early 80s, we really didn't know anything about AIDS or HIV. So maybe sometimes we wore gloves if the situation was particularly dirty or bloody when trying to put an IV into someone, but most of the time we did not. I think we washed our hands, but we didn't wear protective eyewear. And we felt, we kind of competed with each other to see who could be best, because we felt this was best for our patients. And indirectly, we formed a vascular access team at our hospital. We became known as the experts, and we would be called upon various units to place peripheral IVs in people that the staff could not do. Then I left probably the hospital in the early 1990s. I became PIC certified. I was one of the first nurses in the state of Maine to do this, and I was extremely proud. I was so excited to be able to have an alternative option for our patients. And my patients, at that point then I was in home infusion therapy. And it was really important to us to maintain one device for that length of therapy and to be responsible for our lines. We took it very seriously. We enjoyed what we did. I worked for a progressive company, and I joined AVA in the 1990s, and I have not looked back. AVA, for me, has energized my passion, and it has reinforced over the years what I believe is the right thing to do for the patient. Not only is it important to identify early on what's the correct line to use for that patient's therapy, but it's also equally important to make sure that we're placing these lines in the right site at the right time, and that we're using the correct size for that patient. In 2004, I developed breast cancer, and I had met a representative who had attended a network meeting that we had had, and they had a new Metaport device, and it was designed specifically for women with breast cancer. So I went to my surgeon and I asked her if she could place this in me. And she did. And I was thrilled. But then when I went to receive my chemotherapy, the nurses where I went were very nice, wanting to do the right thing, but they did not manage my Metaport. They didn't access it correctly. They didn't flush it correctly. They weren't washing their hands. They weren't cleaning the site appropriately. So after 2 visits, I brought in my own dressing change kit and started accessing my own site. I had done this with patients. I had taught them how to do this in home, and I felt it was just a natural extension of knowing how to manage your Metaport. So I had to endure a lot of comments, and it was very difficult to be a patient that was a nurse that kind of carries a stigma of its own, let alone one who's going to come in and place their own needles to access their catheter. And I listened to comments like, "We've never had a patient like you before. What's the matter? Are you afraid of an infection?" You know, little things, but I didn't care. And I hoped that through my example, I inspired or encouraged other peers around me to find out how to do it right. I realized again that they weren't saying or doing this because they didn't care. It was due to lack of education. So then that became my passion and mission, to make sure that we have the education for patients and their caregivers, and that it's up to date, and that people do the right thing. So that as a patient, especially if you know what you need to do things correctly, you're not put in a situation where you have to say something to that person. It's very difficult to do that. And I think we've come a long way. I also am a clinical nurse trainer for a couple of companies. And one of the things I have found in doing this education to nurses throughout the Northeast, they really want to do the right thing, but they don't know what that right thing is. And part of this frustrates me, because what we teach and what we continue to strive to educate and teach today is what I was doing 20 years ago, teaching my patients at home the same things. So I am very excited to be part of AVA. I know that AVA is growing, and it is slowly being recognized as the voice of vascular access. And I'm excited to think that someday down the road, anytime our patients require a vascular access device, they don't need to worry anymore about, is this going to be an issue or cause any complications? And this is my story.